We're going to move into the risk management section of the day, and our next presenter will be Dr. Trusandra Taylor, who is the Medical Director of JEVS Human Services, a methadone maintenance treatment program in Philadelphia. Dr. Taylor served as a consensus panel member for the development of TIP 43 and is a resident, national, and international expert in risk management issues, which is a topic for her presentation. Dr. Taylor.
Thank you. Well, I want to start out by saying that I am one happy lady right now. I am very pleased with the turnout, the quality of the presentations, and it's such a pleasure to look out and see so many of my friends and colleagues. I was saying to someone earlier this morning, I said, this is better than a family reunion. So this is great. So I want to thank you for all participating in this event. I do want to spend a brief moment talking about how this came about. I had the privilege of working with Dr. Schuster in a similar project, and actually I stole the idea from him when we came together for the project related to buprenorphine. And after that, because it was such a successful project and event, and that's how the idea came about. So I called Roland up and said, we got to talk. Because, I know there's this issue about developing guidelines or some kind of consensus about benzodiazepines. This is what we ought to do. Now, today's event is a kickoff conference. We're establishing a dialogue, and you're hearing some excellent information, and I'm, again, just pleased with all of the presentations and the information that was provided. But the next step, and I don't want to take from Dr. Cohen, but we want to establish a working process to develop some guidelines and to develop consensus based on evidence-based practices and so forth. So you're going to hear more about that. So I wanted just to give you some brief comments. And I have to say that I took this idea from community care because that was so successful with buprenorphine. Okay. Now, risk management. I want you to put on your risk management thinking caps. And you say, well, thinking about this topic today, what does it have to do with risk management? Well, this is why. And I don't know if this is projecting very well, but this is patient X, a 33-year-old male in our program. And to give you a short history, he's been in treatment since August of 2011. And lo and behold, you can see he was hospitalized. He and his girlfriend had a baby recently, and things are going fairly well, but a lot of problems, a lot of psychosocial issues. So as you can see here on the date, the blue, January 2nd, he was admitted to the hospital. Had an argument with the family, so New Year's Day, he decided to tie one on with alcohol and benzos. Ended up found on the street, unconscious, and was rushed to the closest hospital, which is actually a community hospital. Won't say where. But he was admitted to the hospital, intubated, and then transferred to a hospital here in Philadelphia. And as you can see, what does it say here? Diagnosis. I don't know how well it projects in the back. Benzo overdose. Okay. Coming down further, you can see this was his dose of methadone, 60 milligrams. Now, I combined these pages to get it into one page, but this is the discharge instructions. Do not take Xanax. Also, do not take all psychiatric meds. I don't know what that's about, but anyway, this is the kind of instruction he was given. And you can see here at the bottom, he was hospitalized for 2 days there, and again, initially at the other hospital. So this is why risk management is relevant. 3-day hospitalization for a 33-year-old male. Now, in the time that I have, I'd like to focus from the MAT perspective related to risk management. I'm going to talk briefly about some risk identifiers revolving around what we call the standard of care, looking at it from the focus of the regulatory, medical, and legal perspectives, and then briefly touch on the role that practice guidelines play. And hopefully I can outline some strategies to minimize and prevent liability. Now, in the opening remarks and all throughout the day, I paid attention to elements related to risk management. Morbidity, we've got excellent data. We've talked about the variety of clinical settings, coordination of care, collaboration, and we just heard discussion about drug-drug interactions and pharmacology. This is all related to risk. Now, risk management in healthcare is defined here. These are two definitions that I like, and you can see the references at the bottom, but it involves managing and dealing with risks, and the idea is to minimize accidents and to prevent them. In healthcare settings, I like to think of it in terms of 4 basic areas. First and foremost is patient safety. You want to prevent any adverse events. There's always the issue of quality of care. And of course, patients have rights to treatment and choice. Now, from the medication-assisted treatment perspective, and I'm primarily talking here about OTPs, you have to look at risk in a different sense, that our patient population has what I call unique characteristics as opposed to the general population. The medication alone, what we call opioid agonist medications, methadone, have pharmacologic properties where it just outlined that add additional risks. And then there's the overall issue of management of medications, adherence to treatment, and challenges that our patients present. You heard, I think earlier, the term standard of care. Standard of care is something that is recognized in a sense in terms of the medical aspects, regulatory, and from a legal perspective. From the medical definition, it's defined as a medical or psychological treatment or guideline, and it can be general or specific. Another way of defining is it specifies appropriate treatment that is based on scientific evidence and collaboration. And lastly, the emphasis in terms of the standard of care is what would a reasonable person do under these circumstances? You're going to see this term, reasonable person, later on. As a physician, in terms of the standard of care, it's recognized that a physician has the duty to inform the patient of any risks and any circumstances that might occur, and the patient needs to be fully informed of this. From the legal standpoint, in terms of standard of care, it's recognized that we're talking about the degree of attention, prudence, and caution that is required when a patient is under your care, your duty of care to that patient. Another way of defining it is in terms of what a prudent or sensible professional would do with similar training and good standing in providing care. Again, you see the common denominator and words of prudence, reasonable person under circumstances in terms of what they would do, duty of care, and failure to do this is defined as negligence. And you don't want to be accused or determined that you were negligent in your duty of care to this patient or in the circumstances. Now, standard, and the defense is sometimes in cases taken in this sense that the standard is subjective. In other words, I've seen cases where the question was, well, what was the standard of care in Pittsburgh or Philadelphia? Is that the standard of care in Iowa? And some cases have been won because it is subjective, but there's also some commonality in terms of what is reasonable, what is prudent, and what is good care. Negligence is defined and established by law, as stated here, as any action that involves an unreasonable risk of harm under the circumstances. And again, it boils down to what would a reasonably prudent person do under these circumstances to avoid the risk and to avoid any adverse events. It goes back to our British heritage, going back to as long as the 18th century, and it's still, relevant today, and it, as is stated here, represents the widest range of tort cases for wrongful conduct, wrongful deaths. And if you've had any experience with that and have read any of the documents, the language in those cases revolve around these terms. What would a reasonable person do? And the event is a wrongful death or a wrongful injury. Now, in terms of the regulatory standpoint related to standard of care, we presently have the guidelines that are established by the federal government in what we call 42 CFR. So you have regulatory, legal, and medical. And for methadone, it's 42 CFR, and also the CSAT accreditation guidelines. For buprenorphine, we have what we call Data 2000, which goes back to the original approval and the structure for setting up buprenorphine treatment with the registration with the DEA and physician waiver. Now, practice guidelines, and we're going to talk about that. For the most part, they're either empiric or they're actually evidence-based. Empiric meaning revolving around observation or experiment. It's guided by your clinical experience and not theory. What we're talking about for the most part today is using more evidence-based practices, but many of these are what we call physician-centric. Some call it cookbook medicine, and it's not really good, it's not really cookbook medicine when they're really constructed with a holistic viewpoint. But they really are based in science, and there should be integration of the science with the clinician's training and practical experience. The part I like is that consumers should be able to comprehend and understand their diagnoses and engage in treatment and knowing what the available options are. So when you talk about practice guidelines, I like this definition, and you can see the reference here at the bottom. Risk management in practice, in terms of program components, involve 4 basic processes: risk identification and analysis, establishing priorities for the risks that you identify, implementing the risk prevention strategies, and then strategies to manage the actual risk. Now, what are some common identifiers for benzodiazepine use? 2 big areas that we commonly see: patient incidents and records, reports. Patient incidents, patient X, overdose, adverse drug reaction. Issues of impairment that we see in terms of our patient. Drug test results. All of our patients in OTPs have serial drug tests, and many of them have evidence that they're at risk. We can see, month after month after month, positive drug screens for benzodiazepines and so forth. And then also other incidents involving observations, and complaints, and concerns about patients. I want to talk about the pharmacy and therapeutic reports, prescription records, pharmacy audits, and PDM records. This is going to be very key. We get pharmacy reports right now that have been very helpful in looking at patients in terms of the prescriptions that they're getting, because sometimes our patients don't always tell us everything that they should. So we're seeing information. I didn't know this patient was getting methadone. I didn't know this patient was getting 2 classes of benzodiazepines, plus Ambien. So these are reports that help us identify patients who are at risk. Hopefully in the future, the near future, we'll have real working prescription drug monitoring programs. Right now, in Pennsylvania, it's tied up. You can't get the information as a clinician. It's in the criminal justice sector. We need to have legislation to have this change so that, as was pointed out, as a clinician, as a physician, we can get this information so that we can save patients' lives. It's not to impinge upon their privacy, but if we don't have this information, patients will continue to die of overdose. Impairment is the big issue with benzodiazepines. We've heard much discussion this morning about opinions on appropriate use, but the big issue is impairment. Patients who are impaired secondary to benzos, alone or in combination, are of danger to themselves and to others. There's no doubt about it. Patients who are impaired for operating heavy equipment, driving motor vehicles, and so forth. Identifying impaired patients in a program involves everyone: your support staff, your medical nursing staff, the clinical staff, family, and other patients. You need to create what we call a climate of awareness, educating patients and having policies and procedures to inform them of this. It really involves what we call the total OTP, or medication-assisted community, and creating this climate awareness. But in this climate of awareness, red flags need to be identified. You know what I'm talking about. Evidence is ignored. And the MAT, these are the kinds of things that you see in the reports that are written up about cases. They should have known. Patient was falling asleep at the dispensing window, but yet they were dispensed. That's what I'm talking about, a red flag. You should have a routine process for observation and assessment for impairment for any foreseeable risk. Drug testing results should be followed up upon, not just month after month after month. And you need to monitor the methadone dose and adjust it, and be prepared to do that, and have patients understand why you're doing this. Now, you see no tolerance? There should be a no tolerance policy for impairment. I'm not saying benzos. You should not tolerate impairment, and you need to communicate that to patients. And any behavior that is dangerous really needs to be reported to the authorities. So you need to have phased, informed consent. It's not just when the patient comes into treatment the first day, they sign consent. It needs to be continuous. And patients need to understand that they need to allow you to collaborate with all of their prescribing physicians. And they need to have an understanding about that, to sign a release of information and to cooperate. It's important to discuss these concerns with patients privately when they're impaired, or you're assessing them, not in front of the dispensing window or in the waiting room. And you need to use diagnostic tools for assessment. You need to be prepared to make dosing decisions. Your staff needs to be educated and trained and competent in this area. And as was pointed out, document, document, document. And it should be adequately documented, and you need to revise the treatment plan appropriately. Lastly, I want to point out, again, in terms of a summary here, you can't ignore this. You have a duty to take action from a risk management standpoint. You need to take reasonable action in terms of what a prudent person would do. They would not simply ignore the events that are taking place. And you have a legal duty Programs can't say, well, I didn't know. But cases are legally being won by the plaintiffs because the program did not recognize their responsibility and their duty to act. That's all I want to say, because I want to have time for questions. Over there. Do we have time? Or can we do it in the Q&A part? It's up to them. Right there? Come on, Dr. Sayman. Question?
Actually,
Can't hear.
earlier today, we saw how many people actually are using benzos in MA programs, actually doing the things that you've identified here that must be done.
I can't speak for all programs, but I will share with you that it is time intensive. And it involves a lot of time. It's like the Pareto principle, 20% takes up 80% of your time. And that's what these patients who are impaired represent. And it does take time in contacting prescribing doctors, talking with patients, convincing them to allow you to do this. So I'm outlining what should be done. I cannot speak to say what other programs are doing, but I am doing it, but it is time intensive.